Well, good afternoon, everyone. Welcome to today's webinar, The Finalization of Healthcare. I'm Jessica Mantell. I'm the director of the Health Law and Policy Institute here at the University of Houston Law Center. So just a little housekeeping before I introduce today's speakers. For those of you that are taking this for CLE, tomorrow you should receive an email that will give you the information that you need to self-report that you've attended today's webinar. And then at the very end of this webinar, we're going to put up a screen that will have the QR code that you need as well. So let me introduce today's speakers. We have Erin Fusay-Brown. She is a professor of health services, policy and practice at Brown University School of Public Health, where she's a member of the faculty for the Center for Advancing Health Policy. So Professor Fusay-Brown is an expert in healthcare financing and healthcare competition, and she's particularly well known for her research and commentary on private equity investment in the healthcare space. And she regularly consults with federal and state policymakers on various healthcare policy matters. She has her law degree from Georgetown University, as well as a master's in public health from Johns Hopkins and her undergraduate degrees from Dartmouth. And then our second speaker is Hayden Rooke-Ley, also joining us from Brown University School of Public Health, where he's a senior fellow whose research focuses on corporate consolidation in healthcare, Medicare and Medicaid financing, and healthcare workforce issues. And like Professor Fusay-Brown, he's also regularly advises policymakers on healthcare matters. He received his law degree from Stanford and has his undergraduate degree from Williams College. So welcome to both of you, and we'll start with Professor Fusay-Brown.
Great. Thank you so much, Jessica. I will share my screen and begin this conversation. So thank you so much for inviting us to present on our work, which is an article that Hayden and I recently published called Healthcare Financialization. And we're going to sort of take this time to discuss some of the ideas behind what we mean by healthcare financialization and also the policy and research agenda that flows from it. So we are this is just an overview. The article was published earlier this year in the Journal of Healthcare Law and Policy out of the University of Maryland. It was the result of a collaboration where I had given the Rome lecture on this topic, and then we developed the article that followed this lecture series. And so it was really again a conversation that was quite a ways in the process. So some of the examples that we're using, our thinking has changed as we worked on it. But we came up with a definition of what we mean by healthcare financialization, and also provide two case study examples of what we mean by healthcare financialization, and then talk about the policy concerns that this type of financialization raises. And then I'll turn it over to Hayden to talk about the policy agenda that this engenders, including some of the types of policies that we've written a lot about various policies to address some of the specifics of healthcare financialization. And this is somewhat of a blue sky thinking in terms of where we think that the field needs to move next. Again, invite others to join in this effort to the extent that you're also convinced that financialization might be an issue. So I'm going to start with a story. There was reported in the Boston Globe a story about a woman named Sungita Rashid. She was in 2023. She was 39 years old. She was expecting her first child, and she and her husband chose to deliver their baby at St. Elizabeth Medical Center in Boston. She was admitted in early labor to the hospital, and a couple days later gave birth to her daughter. But as she and her husband, were taking pictures and celebrating their newborn, it turned out the hospital was in pretty tough financial shape because St. Elizabeth's was part of Steward Healthcare System. And Steward was the product of a private equity acquisition several years prior by the private equity firm Cerberus Capital Management, which had bought the nonprofit hospital system back in 2010 and converted it to a for-profit system. And in the process, Steward Health System cut corners, didn't play it understaffed its hospitals, didn't pay its vendors, and started to cut back on supplies. So a day after Sungita gave birth, her abdomen actually filled with blood and she was rushed into surgery. Doctors needed an embolism coil to block the bleeding, and that is a type of device that is typically, supplied in any level 4 maternal care center. But because the hospital hadn't paid its suppliers, the coils had been repossessed by the supplier, meaning that St. Elizabeth's didn't have what it needed to treat Sungita. And in a last-ditch effort, the medical team transferred her to another nearby Boston hospital, but it was too late and Sungita died in surgery. And so Sungita's story is emblematic of a broader crisis that's facing healthcare in the United States, and is a crisis that we say is rooted in financialization. The chilling reality is that more patients like Sungita might face similar, either life-threatening, or communities might face loss of access to key healthcare services as a result. All right, so what do we mean by financialization? So the definition we came up with for this paper is that financialization refers to the shift in the primary objective of the healthcare institution from production of patient and community health to the extractive production of wealth for equity owners and management. So for investors, basically. And the idea is that, of course, there's always been, for as long as, we've been in the United States healthcare system, there's always been this problem of sort of profit opportunity in healthcare and in medicine. But we do think that our healthcare institutions traditionally have an objective of maximizing the community's health, or if it's an individual provider-patient relationship, maximizing putting the best interest of the patient first. And so what we say financialization marks is this shift where, again, profits for investors or managers become prioritized over patient health and community health. And this process, we argue, is fundamentally extractive, right? We fund the healthcare system so much with public program dollars, with our own dollars through our paychecks and our premium payments. And that this process of sort of, taking all of this, capital and spending out of the healthcare system, and distributing it to the financial sector, is a form of extraction, which we characterize as financialization. So traditionally, because we think of healthcare systems we're aimed at producing goods and services for the health and the patients of the community, financialization really, shifts or flips this paradigm on its head, where the primary goal is to create profit for investors. And there are three key elements that we think characterize financialization in healthcare. The first is that this results in and from a shift in governance. Financialization is accomplished by means of a shift in the governance and decision-making authority from healthcare providers, whose priorities, again, are professionally and legally and fiduciarily obligated to focus on patient care, to financiers advocating for capital extraction or profit maximization returns for investors. So the governance of the healthcare entities, or the providers within the healthcare system, again, shifts away from the entities that are closest to patient care upstream to sort of these centralized corporate actors. Second, we observe that there is a shift from value creation to financial engineering. And I'll explain what I mean by that. Financialization emphasizes short-term profits through financial engineering, or these sort of like revenue-generating tactics, generally speaking, that do not provide additional health care or health outcomes, or even quality care to the healthcare, those who are consuming the healthcare. In that way, there's not really producing societal value. It's instead, it relies a lot on financial engineering tactics that simply increase revenue without necessarily increasing, again, quality or value of care provided. And this could be through arbitrage opportunities, through payment loophole extraction or exploitation, or consolidation, market power increases. And then finally, this leads us to the third observation, which is that financialization leads to a delocalization of governance, and a delocalization and consolidation of the control of these entities. So financialization actually thrives on delocalization, which is removing governance about community assets and healthcare from the local community and consolidating within a large centralized entity. And in a health system with local governance, this allows the entity to avoid accountability. So when we think about things like accountability to avoidance, it's accountability to what? It's reputational accountability, it's legal accountability and liability, and it is also sort of financial accountability and liability. So, how was it that St. Elizabeth's was able to continue to operate in this way? Again, was in some ways because of the consolidation, the delocalization, and the avoidance of accountability that comes with financialization. All right. So the crux of financialization really can be summarized as follows. It's a transfer of like power and control from healthcare entities, again, that owe duties to the community or to the patients, to the financiers, right, to the shareholders. And that comes with a series of characteristics that we think could potentially be problematic. All right, so how do we know when we are encountering financialization in the healthcare system? I think that we selected two examples of phenomena that we think are emblematic of financialization. There's certainly not the only two, but it's sort of our test case for coming up with this definition and these characteristics. The first example is the role of private equity. So private equity has emerged as a key player within the landscape of financialization. And over the past decade or so, private equity investment in healthcare has increased significantly, reaching nearly $1 trillion in the last decade annually. So, or over that decade time. And initially, private equity targeted hospitals and nursing facilities like the Steward Health System. But in recent years, this investment has shifted towards physician practices, outpatient facilities, behavioral health services, and other types of providers. So unpacking the private equity model is somewhat, again, a test case of whether or not financialization is occurring. So the private equity model invests funds using pooled investment funds from investors, limited partners, and a general partner that drives the investment from a variety of institutional investors. And these private equity funds manage these assets, and they take that capital to go draw down additional debt. So this is why often these are called leveraged buyouts, because they're highly leveraged. There's a lot of debt involved, and actually, contrary to its name, not so much in equity. And then it basically uses that bolus of money to invest in target companies. In the case of hospitals, it may be hospitals or nursing homes. It could be physician practices, and it acquires usually a controlling stake in those companies. The goal is to make, significant returns in a relatively short period of time. The limited investors expect to receive their payouts within, 3 to 7 years on average. And so the whole goal is to increase revenue in that time period, reduce costs, and then sell the entity to another buyer at the end at a significant increase in value. So again, quickly maximize profit, quickly reduce costs, and sell within a short period of time. So how does private equity, financialize healthcare? Those characteristics that I mentioned, the fact that it uses a lot of leverage and debt, the fact that it uses has a short-term investment horizon, creates together this, what we've characterized or others have characterized as a moral hazard. It's an asymmetry between the amount of risk that the private equity fund bears versus the sort of upside, the upside benefits that it gains from the investment. So it basically allows the investors to load all of that debt obligation on the target company. So on the hospital carries the debt. The physician practices carry the debt and have to service the debt. It's not the investors. And the investors can capture the profits or the transaction fees that come from selling the real estate or entering into lucrative management contracts. But the entity that it was acquired is the one that has to carry the debt moving forward. After all, the long-term risks then of these risky strategies, for example, of doing things like, entering into a sale leaseback arrangement with a real estate investment trust that strips the assets and, puts the hospitals like St. Elizabeth's into an upside down financial position where they can't pay their bills. That is something that is borne, that liability, that risk is all borne by the hospital, not by Cerberus. Cerberus left many years ago before Sungita, went to the hospital, and it sort of had taken its investment proceeds and left, exited the investment well before any of the accountability came calling for Steward. So the private equity firm Cerberus, again, because it had exited investment with lots of profit and lots of revenue from the various strategies it employed, is an example, we say, of the financial engineering tactics, right? Again, it didn't make Steward health system a more viable, more robust, higher quality, better place to provide care. It basically took a lot of that extraction in the form of real estate and other types of transaction assets out of the Steward Health System, and that is financial engineering. And so it's willing to take risks without the sort of reputational, financial consequences. Even though we've all heard about Steward in the news, and there was, congressional hearings and lots of reports lambasting the CEO, Ralph De La Torre, we've heard nothing about consequences rolling all the way up to Cerberus Capital, again, which has to this, I think, to date, paid no fines, no liability. There has been no untoward consequences for the initial private equity investor. So that's an example of financialization. Second example of financialization is vertically consolidated Medicare Advantage entities. So we, Hayden in particular, but we've been studying the rise of Medicare Advantage, which is the private health insurance version of Medicare, and the rise of vertical consolidation by these insurers, buying up physician practices, home health, and other, PBMs and other types of entities within the supply chain in a vertical effort to really consolidate the entire healthcare supply chain. Why would it do this? Medicare Advantage now enrolls over half of Medicare beneficiaries. It is paid on a capitated risk-adjusted basis, meaning the Medicare Advantage insurer stands to make more money the more sick the patients appear to be in its diagnosis. So the beneficiary is coded. Each individual beneficiary is coded based on diagnoses, and that goes into a risk score, and the risk score basically increases or decreases the capitated payment received by the plan. So we know that risk score upcoding is a strategy that is being used, again, to make the patients look sicker by assigning them more diagnoses, but not providing any more care, not providing any other follow-up or any better care, but basically just making them appear sicker as a financial engineering mechanism to gain more Medicare payment dollars. And we know that the Medicare Advantage companies have been engaged in a bunch of vertical acquisitions of physician practices, in particular, targeting the ability to take advantage of the risk score game. And it does so in particular by acquiring primary care practices. The biggest entity here that we all hear about and know is United Healthcare, which is both the biggest Medicare Advantage insurer and also the biggest employer acquirer of physician practices through Optum. And so we have seen that they will buy provider groups in order to gain access to the providers that serve the Medicare Advantage beneficiaries so that they can have access to their electronic health records, they can code higher risk for them, they can send home health aides or nurses to their home in order to, again, have these health risk interviews where they can document more diagnoses, again, with an eye to increasing revenue. Again, none of this necessarily translates into more or better care, but it results in much significantly higher payments to the tune of, 75 to 85 billion dollars in annual overpayments, depending on the year, just from these types of strategies. So we know that this is happening. MedPAC has documented it year over year. It has not been control, but it is a strategy, again, that it displays sort of all the hallmarks of financialization, and that the entity that gains the reward is the insurance company. The tactic used is financial engineering, and then the outcome is a sort of inability to actually sort of follow the dollars and capture. It's basically an extraction of public Medicare dollars that goes to return to the insurance companies. And it's not just United that does this. All the big insurers in the Medicare Advantage space are doing this. The same playbook, whether it's CVS Aetna, buying Oak Street Health or other. Humana also has a big play into the physician practice space. Okay, and I'm going to just end on policy concerns before turning it over to Hayden. And that is that the risks of financialization really fall into three big buckets: cost increases, harms to patient care, and harms to the workforce. So in terms of the cost increases, there's been a lot of empirical evidence, a lot of it done by our colleagues at Brown, but others as well, who've documented what happens both when private equity buys practices or hospitals, or when Medicare Advantage vertically acquires physician practices as well. We can see significant consolidation effects, price increases, spending and utilization, usually through intensity increases as well. So we know that these are not minor increases. Sometimes they're double-digit increases, and again, these cost effects are making healthcare affordability, even worse in these areas. The second is harms to patient care. I mean, the story that I opened with of Sungita Rashid is a very, telling example of this, but it also can interfere with patient care in other ways. We have seen that private equity acquisition in facilities of hospitals and nursing homes in particular does lead to adverse patient outcomes, more adverse patient outcomes, including more avoidable hospital infections, 25% increase compared to non-private equity-backed hospitals, and a staggering 11% increase in mortality in short-stay nursing homes. Usually, both of these effects, these quality effects, are driven by the effort to reduce staff as a method of cutting costs. So there's a workforce suppression or workforce reduction cost-cutting strategy that is inherent in financialization in the healthcare system. And then finally, the workforce, to the extent that the smaller staff is asked to do more with less, they're also sort of burnt out, demoralized, subject to declining satisfaction because their job has become harder. They're answering to bosses who really are focused on the bottom line, and so they become sort of widgetized in this process, and it can make the workforce more likely to exit, to churn, to be replaced, and really just to leave the profession altogether. All right, so given that I've painted this lovely picture of what healthcare financialization does and can do, I will turn it over to Hayden to talk about what we can do about it.
Great. Thanks so much, Erin, and thanks everybody for joining us. So turning to solutions here, I think this begins with us acknowledging that the current system of governing our healthcare system, our current kind of policy paradigm, has been inadequate to address financialization that Erin just depicted, and generally, I think, to effectively govern our healthcare system. We, of course, continue to see exorbitant costs in U.S. healthcare, and again, this related and also independent phenomenon of financialization that we think is coming to characterize all forms of healthcare delivery and really every segment in different ways of our healthcare system. So, of course, forces the question of how can healthcare law and policy mitigate this kind of extractive quality of the healthcare system that we identify here? How can our healthcare institutions operate in the interests of patients, clinicians, and communities? And here we're again taking a normative position that power has been delocalized from these nodes in a harmful way, and that the locus of decision making and power in the healthcare system ought to reside between patients and physicians and their local communities. Next slide, Erin. So before I kind of walk through our three-part framework, I do want to connect our thinking here to the intellectual tradition that we draw on. In the paper, we note this at the end here. And this is the public utility tradition, or what used to be known as the law of regulated industries. This is an aspect of law and policy that's gained greater prominence both in actual regulation and in the academy in recent years, particularly focused on big tech platforms as they've emerged. But really, it was a legal and policy innovation in response to the first Gilded Age. Thinkers in the progressive era and into the New Deal were worried about certain sectors of the economy that had a unique public interest, that were vital to the common good and the public interest, and where aspects of financialization that we describe here really come to characterize those sectors, where traditional liberal market ordering, laissez-faire markets were not delivering as an instrument, were not delivering optimal social goods, social good, and we began to see a lot of the buildup of private power exercised in the political process, and a level of extraction within those sectors that were concerning policymakers. So there was a whole kind of toolkit that I'll touch on and I'll sort of weave through all our policies that these policymakers were thinking about. And ultimately, the idea here was to exercise a greater level of social or democratic control over these sectors that were, again, understood to be vital to the public interest. In healthcare, healthcare has not traditionally been connected to or identified with this legal and policy tradition, but there's been, as I'll talk about here, there's been aspects of the healthcare system that have expressed a lot of the sort of public utility toolkit, particularly in the kind of mid-century period and the kind of health planning period before the turn to, in the 70s and 80s and 90s, the turn to managed care and what we think of as a retreat from some of these principles. However, as I'll talk about here, we're beginning to see at the state level, actually across in red and blue states, a resurgence of aspects of the public utility tradition that might signal a different kind of approach that's emerging here to address the ills of our healthcare system. Next slide. So the framework that we lay out is kind of three broad pillars, again, proposing a policy framework and also inviting others to think through as a research agenda how to kind of build out this way of thinking about governing our healthcare system. The first pillar is payment policy, kind of in the health policy idiom, payment policy or reimbursement policy. But really what we're proposing here, what we're talking about, is an emphasis on rate regulation or public price administration. And this is something that continues to be today a feature of our healthcare system when we think about our public programs, but has been one that we've departed from in the kind of last 30 or 40 years of healthcare governance. There's been with the rise of the managed care movement and health maintenance organizations and the ensuing privatization of our public programs. Erin discussed Medicare is now majority run through private insurers, same with our Medicaid system. There's actually been a quite explicit departure from public price administration, setting prices for services, and instead trying to pursue cost containment and cost allocation in a different way. Again, this is represented, for example, by the retreat of states regulating prices of, for example, their hospitals, which was quite common in the 60s and 70s, towards this idea of vertically integrated managed care companies, and then also in our public programs moving away from traditional, for example, fee-for-service Medicare towards forms of managed care. And one of the consequences here is a system that that tries to foster price-based competition, but ends up, instead of delivering value, places immense priority and advantage on consolidation, on just being large to negotiate high prices. And this leads to some of the financialization tactics that we talk about in the piece, the classic private equity roll-up of consolidating market density in a given region to try to drive up prices. We see the same thing when hospitals consolidate to have that negotiating leverage, and this results in forms of essentially price gouging in the system. That's a product of a system that's trying to foster price-based competition. We've also seen, as the move away from price regulation or fee-for-service, the really complex and burdensome forms of reimbursement that oftentimes require medical practices, other medical care delivery institutions, often smaller ones, to be forced to access forms of capital because it's so complex and complicated to operate in the system today. So in the piece, we propose that it's worthwhile for policymakers to draw on what is an emerging resurgence of state-level price regulation. I have here clipped the passage of price caps in Indiana that passed last year, but generally commit much more full-throatedly to a system in both private insurance and public insurance of competent price administration as a way to neutralize the advantages of size in the healthcare system that are the source of a lot of extractive behavior that we see today. Next slide, Erin. The second pillar that we talk about, we call market shaping. How do we want to structure and organize markets in our healthcare system? What are the forms of competition we want? Where do we want it? Where don't we want it? And what do we want our healthcare institutions to look like? Erin mentioned the transformation of our largest insurance companies into sprawling vertically integrated entities, and a growing concern that maybe this vertical integration, instead of producing the efficiencies that were always envisioned, might instead be actually producing forms of extractive behavior. Erin talked about the gaming of the risk adjustment system or the medical loss ratio, essentially profit caps in the insurance system. Those are forms of using vertical integration to pursue regulatory gaming or evasion or arbitrage. There's increasing concerns, especially in the drug supply chain, about the conflicts of interest that might arise when these sprawling entities are owning numerous aspects of the healthcare system. When an insurer not only owns physician practices, but also owns pharmacy benefit managers, key intermediaries in the drug supply chain, also owns pharmacies that rely on PBMs, also own private label drug manufacturers. Essentially, we see these conglomerates move into drug manufacturing. All sorts of incentives then arise to engage in commerce in a discriminatory basis to favor your own affiliates, and on a discriminatory basis to independent or unaffiliated providers, for example, your independent pharmacy. So there's been, we're seeing in a number of states, efforts, one successfully, although it's hung up in court right now, but legislatively, to actually break up PBMs from pharmacies, saying we actually don't want this form of vertical integration in that aspect of the delivery system. There was just a recent piece of bipartisan federal legislation proposing to separate many different aspects of the healthcare system, insurers from healthcare providers, PBMs from pharmacies, and drug manufacturing. And this too is an interesting development, and I think is best understood as a provocation to the existing paradigm of governing our healthcare system that in so many different ways has actually tried to facilitate forms of vertical integration. And instead, we see here, again, drawing on actually many aspects of the public utility tradition that we've seen in banking or in telecommunications. When we think about the big conglomerates like AT&T and the way that antitrust law or legislative policy has gone about regulating them, there's been breakups, again, actually both through the courts, through antitrust, when there was more robust vertical antitrust enforcement, and through legislation, saying we actually don't want to structure markets this way. We don't think forms of vertical integration are net positive. Let's encourage competition on the basis of, within a given market segment. Next slide. Another aspect of this kind of market shaping category that we talk about is attention to ownership and governance. And this is part certainly of the public utility tradition, but it's also very much been part of the healthcare regulatory tradition throughout many different aspects of our healthcare system. There have traditionally, more so historically than today, although very much in many ways still today, forms of regulating who can own and control aspects of the healthcare system. One example of this is the traditional ban on the corporate practice of medicine. Most states actually still have nominally on the books laws that say that for-profit medical practices actually have to be owned by licensed physicians and other clinicians in the state due to concerns about, for example, bankers and financial investors owning the medical practices and the point of care delivery. Those laws have essentially gone unenforced for decades, but there's a resurgence in a number of states, and the passage of one bill in Oregon that has tried to close the various loopholes that have been used to get around these laws and really breathe life into this idea that we actually care about who owns our healthcare delivery institutions and want to legislate in that regard. There's also been historically a strong tradition in healthcare, and again, certainly in the kind of the public utility tradition of public options and public ownership. Healthcare still, I think about 30% of hospitals are still publicly owned. This number is down from previous decades and less than many of our peer nations, but nonetheless is a significant aspect of how we organize and who our healthcare system and who owns healthcare providers. A related aspect of or related part of ownership is governance. What are the governance requirements of our healthcare institutions? Is it that our nonprofits, for example, which we argue have begun to express this kind of change in ethos, this cultural change towards financialization, where the profit motive becomes not an instrument, not a result, of delivering good care, but becomes the ends in of itself? Has something changed in in our governance requirements of nonprofit institutions that have allowed them, or in some ways maybe even encouraged them, not to really act like charities, but instead to act like institutions that, again, are primarily pursuing profit generation rather than promoting patient and community health? And then, specific to a lot of the examples that Erin discussed around private equity, do we see a concerning level of dividend recapitalization, sale leasebacks, over leveraging of the hospital assets, quick turnaround periods of sale that we think are dangerous, and therefore should governance requirements think about limiting or prohibiting certain forms of governing these institutions that are systematically, we think might be dangerous and might lead to the sorts of some of the calamitous outcomes of a few of these private equity acquisitions of hospitals that have gone bad. Next slide, Erin. Okay, and let's see the time here. For our kind of the final aspect of, or the third pillar of our framework here, we talk about building and allocating supply in our healthcare system, and how we should think about that from a legal and policy and kind of governing public governing perspective. I think the first thing to say here is that there's oftentimes a defense of sort of inviting any sort of capital investment in the healthcare system, that we want any sort of capital investment because healthcare institutions need capital. And in some cases, that's true. But first, I want to identify that in many cases, that's actually not true. Our healthcare system, as we all know, is incredibly expensive. There's a lot of money here. And the majority of it is publicly financed. About 70% of our healthcare system comes from taxpayer dollars. Most of this through our public systems, but also, for example, the nonprofit status of institutions or the subsidies that private insurance gives. So we have a largely publicly financed system. And oftentimes, acquisitions of healthcare providers aren't due to necessarily need, but what is seen as a lucrative transaction between two parties. So that's important, I think, to understand as we think about whether we want, total sort of permission of any sort of capital coming into the system in any sort of way. Now, it's certainly the case that there are a lot of institutions that are distressed. And as for reasons, we've discussed here, we've organized a system that systematically disadvantages some institutions over others, smaller providers, those that rely on, for example, lower paying payers. And in this sense, we want to think about, are there alternative sources of capital that we can provide to, so we have a system that doesn't require, providers, for example, to turn to any form of potential capital investment. And here, first, I want to return to the first pillar that I discussed around reimbursement policy or payment policy, how providers are paid. I think, one thing we say in the piece is that we should think about reimbursement policy as capital financing policy. So much of the healthcare system is now financed publicly, as I mentioned, but through how we pay for care once it's delivered. And if we think about that as a form of capital financing, it really doesn't make a lot of sense. And it really causes a lot of problems if we set up a system where providers are basically making different margins on different types of patients. This is another argument for standardizing payment policy, So you don't systematically have a provider, for example, who sees a lot of Medicaid patients or who is in a rural area making lower margins when they see a patient and therefore having more difficulty accessing capital, having more difficulty than having to rely on maybe more risky forms of capital. And again, kind of systematically disadvantaging them because our payment policy elects to do so. So that's another argument for thinking about standardizing prices across the system here. But we also might want to think about direct public capital financing to institutions. And here, there are actually a number of systems already set up both at the state and federal level. At the federal level, there's a patchwork of policies through HRSA, which gives grants to, for example, community health centers. There's the USDA has programs for loan financing, small business administration, but there's value, we think, in thinking about these programs collectively and bringing them together and figuring out how can we build on these structures that are in place to provide a reliable and sustainable source of capital for providers who might, for example, need to draw on some loan financing to upgrade their systems. Again, as an alternative, if we're worried about forms of finance capital being the only alternative here. And then we want to think about the clinician supply side of things too. We have a big problem of allocating clinician resources across our system. Many different areas are quite distressed and don't have the basic capacity to meet care needs. Here too, we have a system. Every medical resident in the U.S. is essentially a public employee. This is a $20 billion line item of Congress every year through medical education. As we mentioned, so much of healthcare institutions are reliant on public funding, but our system of figuring out the types of clinicians that we need in the places that we need them is really inadequate and frankly incoherent here. So there's a lot of policy thinking to be done of how do we make sure that we're training the types of clinicians we need and placing them in the places that we actually need. And then the final aspect of this is not just building supply and allocating it correctly, but thinking about how we're managing it as well. If we're moving away from a system that is less reliant on necessarily encouraging all forms of entrants to continue to try to foster this price-based competition, and we're worried about maybe certain forms of corporate ownership or finance capital coming into the system, then it actually makes sense to think about how we're managing entry and exit of healthcare providers. And this, again, is a classic public utility tool of managing entry and exit, and one that we've seen historically and actually in the healthcare system and what we see today taking kind of a new form. So we see a lot of healthcare transaction laws today that are reviewing at the state level entry of transactions. And then we also see the continuation of certificate of need laws, which in the piece, I think try to frustrate a little bit of a growing consensus that these laws are conceptually a problem and necessarily need to be thrown out. We acknowledge that certificate of need laws have been in many times corrupted and taken over by incumbents, but conceptually, there's value to thinking about how we want to manage supply, whether it's a new healthcare technology or whether it's managing technology diffusion in terms of new drugs that are coming online or with AI coming on the system. Having institutions, public institutions, and those that preferably are democratically accountable, how do we think about standing up those sorts of institutions? How do we, in the specific instance of certificate of need laws, maybe not get rid of them, but think about what's a way to make sure that they're democratically accountable and can't be captured and taken over by incumbents, your local hospital system, for example. Okay.
Great. Well, thank you both so much. Such an interesting and timely talk. So we've been getting some questions in the chat, and I encourage others who have questions to go ahead and put those in there. But let me start by kind of summarizing some of the questions that we received. So, you talked about how the corporate practice of medicine might be a tool that can be used to perhaps address some of this financialization of healthcare. But I think a lot of healthcare lawyers have come up with these creative corporate structures, like using management services organizations or friendly physicians to try to get around the corporate practice of medicine doctrine. So we did receive a question about that. I was wondering if you could talk a little bit about MSOs and why some people are concerned about that, and whether you think there's a way to strengthen the corporate practice of medicine doctrine to perhaps get at some of the issues raised by MSOs.
Yeah, I think, Hayden, do you want to take the first crack at this one and then I can clean up?
Sure. Sure. Yeah, so as I mentioned just briefly, the corporate practice of medicine is one mechanism by which healthcare regulation has traditionally tried to structure who owns and controls healthcare systems. Very interesting and kind of fraught history here of the developing power through the kind of mid 20th century of the medical profession, but nonetheless have led to these state laws actually initially coming out of common law, judge-made law, to require that for-profit medical practices are owned either by majority or exclusively by licensed physicians in the state. And as I mentioned, most states actually still have a law like this on the books, but in most states, they don't mean much. And there's been a few different ways that these laws have functionally been eroded. The most common one, especially when we're talking about a outpatient physician practice, when we talk about a private equity owned practice or a practice owned by an insurance company, the medical practice itself actually isn't owned by the corporate owner because, again, it can't be. State law requires that physician practice is owned by a licensed physician in the state, not a company owned by, on Wall Street. So what sophisticated, lawyers and corporations have engineered is essentially a way to, via contract, control the medical practice through a separate corporate vehicle, most commonly what's known as this management services organization, a lay-owned company, corporate-owned, non-professionally owned company that traditionally just provides service to a medical practice that, again, is owned by physicians. Instead, through what's known as this friendly PC structure, this friendly physician structure, captive physician structure, these corporations have figured out how to nominally comply with the law by essentially finding a physician, getting them licensed in the state, and placing them as the figurehead or the captive physician. And then by contract, bringing all the value of the physician practice, all the physical assets, to the management company, and then through control of the physician, of the friendly physician, effectively managing the practice and controlling the practice. So for a given physician in the practice, they don't realize all this corporate sophisticated stuff is going on. They think they're just employed by United or by private equity, and but in reality, they're employed by this friendly doctor who is a separate corporate entity, and just by contract is controlled by this management company. Erin, do you want to talk about maybe what states are doing to address it?
Yeah. So, states, as Hayden mentioned, the state of Oregon, we've also seen other bills in other states that have been introduced. California passed a law, and I just wanted to note Texas is actually a strong corporate practice of medicine state. I probably don't have to tell that to the practitioners who are practicing in Texas, but there have been efforts to try to strengthen statutorily the corporate practice of medicine to address the friendly physician model in particular, or the MSO arrangement. And so I think one of the things that, for example, that Oregon has done is to make the MSO, to basically put more guardrails around the MSO arrangement. So the first thing it does is it just basically reiterates that physicians have to own, the medical practice. But moreover, that there can't be a friendly physician who has a conflict of interest through compensation or equity ownership or other means. Meaning you can't be a friendly physician who works both for an MSO and owns and manages the practice. And another method of control, actually, this California Attorney General just weighed in with an amicus brief in a pending litigation in California on this issue, is that if the MSO has the power to remove and control who replaces the friendly physician, that is essentially total control. And so there are these other mechanisms through stock transfer restriction agreements, through non-compete laws, through other means contractually that you can exert control over this friendly physician, and then essentially functionally own the practice, even if you on paper do not own the practice. And so, Oregon has restricted the use of friendly physicians. It also contains restrictions on what the MSO can and can't do without sort of override veto power by the physician practice, including things like hiring and firing, using scheduling or other types of compensation for employed clinicians to sort of like basically meet revenue targets and other types of things, billing and collection. Again, not that the MSO can't do some of these things on behalf of the practice, but the practice has to retain ultimate control and be the one who gets to say, we actually don't like that you're going out of network with that payer. We want to keep serving those patients. So having that the practice has to retain ultimate authority over some of these key decisions that are operational decisions, but have implications for patient care. And that's sort of that latter piece is also in the California recent corporate practice of medicine law that was passed last year. So I think states are really trying to, again, think more granularly about how the MSO arrangement is like actually structured on the ground today to try to regulate a lot of these particular types of arrangements.
Great. So Erin, in your talk, you talked a lot about the vertical consolidation by Medicare Advantage insurers like United Healthcare. But as you know, there's also been a lot of vertical consolidation happening on the provider side in hospital systems, or Kaiser Permanente being sort of a traditional model of this. But even some of the provider-sponsored Medicare Advantage plans, this is happening too. So do you think that is also problematic? Or is it different than the concerns you identified about this consolidation happening on the Medicare Advantage insurer side?
Yeah, so let's say, when you used to say vertical consolidation in physicians, usually it was like immediately like, oh, hospitals buying physicians or hospitals affiliating with rolling out their own insurance plan. And I think that that's the utility, I would say, of our definition is like, let's run that through the definition. So does it tend to change the sort of control and governance of the entity? Does it tend to use financial engineering tactics? So, for example, hospital physician acquisitions. One of the biggest sort of reasons and revenue opportunities of acquiring physicians if you're a hospital or health system is to take advantage of the site of service differential and tack on facility fees that you previously couldn't do when the independent physician was seeing patients in the outpatient setting or in the clinical practice. Now it's part of the hospital. It's a hospital outpatient department. Suddenly you can charge, many multiples of what you used to. Exact same service, exact same quality. Like it's really no different, except that now it's considered hospital based, and so you can charge a large differential. That is like definitionally financial engineering. No additional value, no additional quality, but just an opportunity to raise revenue. So there are aspects of that, in terms of, again, delocalization or consolidation or avoidance of accountability that could potentially, again, if you run it through our definition, it's potentially a test case for, yeah, I think that some forms of that could be considered financialization, even if the health system acquiring all the physician practices or spinning up of an insurance company is nominally nonprofit. I think one of the things where we differ from maybe some other economic sectors in healthcare is that we have this like big presence of nonprofits. And so it was assumed that a nonprofit can't put profit first. So like functionally nonprofit health systems can't be financialized. And we actually say no. If you actually just look at their behavior, many of them do exhibit all the hallmarks of financialization. Hayden, I don't know if you have other thoughts on Jessica's question.
Yeah, it's a great question, and one I think that comes up a lot when we see these legislative attempts to police vertical integration or renewed interest from the Biden administration. There was a lot of interest, at least rhetorically, on reviving enforcement of vertical integration with what seemed to be some particular focus on insurers. That, of course, triggers this question of, well, what about these vertically integrated hospital systems? And this is what I find, I think is really interesting about this potential development we're seeing, and what I've argued in here and other work. I think we should be much more skeptical of having a policy regime that essentially tries to build Kaiser across the healthcare system. this in many ways has actually been is a way, I think, to fairly characterize healthcare policy for 30 or 40 years. This began with the managed care movement, this idea that the healthcare system was essentially, we wanted to turn it into these sprawling vertically integrated entities that were going to compete with each other. They'd all be vertically integrated. They would proliferate across the whole country. And that was how we wanted to sort of shape and organize the system. This was central to the Clinton proposal in the early 90s. And there was a backlash to this managed care movement in the 90s and early 2000s. But what's really interesting from a policy perspective is, and on a bipartisan basis, we've really doubled down on this paradigm. In many ways, the whole push towards value-based payment is another attempt to try to facilitate risk bearing on the provider side. So somewhat of a conceit that we might not get fully integrated Kaisers everywhere. So the idea was, can we basically get this through contract? Can we force provider institutions to integrate via contract and take on some of that insurance function by bearing risk, to again try to create this system of competing vertically integrated entities as the way that we want the system organized, and importantly, as the way we're going to finally tackle this cost problem. And this is where I think that the kind of a public utility framework that emphasizes price regulation and competent price administration actually offers the alternative to this. And we talk a little bit in the paper about how the shift towards value-based payment and more vertical integration as the way to solve the cost problem is a highly normative decision, and one that's different from a system that more resembles all our peer nations, that controls costs and allocates resources through competent price administration and the attendant kind of value you get there of lower administrative costs. And this absolutely, as I mentioned, is a provocation to the existing approach that says we want these vertically integrated entities, which over decades have not shown themselves in the literature to be better, and in many cases are manifesting the aspects of financialization that we talk about today that Erin discussed. Kaiser recently settled the largest settlement of a risk adjustment fraud allegation in history, $500 million of engaging in the exact same sort of risk adjustment scheme that Erin depicted, that we hear about a lot from United. Kaiser just settled a lawsuit that they've been in for years now, alleging the same sort of thing. So we think, across these institutions, we might see a concerning level of financialized activity and not the forms of value creation that are envisioned kind of theoretically with these entities.
Great. Well, so you sort of brought us back to some of the policy questions. And so I'm wondering, given that there is, activity happening, at least at the state level in this area, are there particular policy levers that you think should be the primary focus? Because you gave us kind of a long list. I mean, would you say the initial focus should be strengthening the corporate practice of medicine? Or should it be this public utility regulation that you're talking about? Or should we be focusing on ways to support independent practices directly, right? So, if you were talking to a state legislator, maybe at the federal level, you're like, focus here first. Do you have an answer to that question?
Well, I always say there's no silver bullet. Like, it was a very complicated and long road to get to where we are. So there is no one answer. Part of the glib answer, I would say, is focus on what is possible. But I think if if there's political will to do something on corporate practice of medicine, and that's solving one issue, which is corporate control or physician practices, but it's not going to get at financialization writ large in the healthcare space. It's not going to get a hospital consolidation. So I think if there's one sort of policy piece that I would say I am watching with great interest, it is the Break Up Big Medicine Act, introduced by Senators Warren and Hawley in the U.S. Senate, so at the national federal level, which would, I think, start to break up some of these large vertically consolidated entities in the healthcare space. Again, we're not going to tinker our way to a reformed healthcare system, but I think that is, a really interesting and meaningful potential move. Hayden, I don't know if you have a different vote.
Sure. And, I'd first again repeat that I think one of the contributions we want to make here is try to lay out how these things fit together, that this is a coherent policy framework. I would maybe then elevate again an emphasis on price administration in our healthcare system. I think this is just absolutely vital both for if we want to protect independent physicians and smaller forms of healthcare governance, and also if we want to actually address this cost problem. We've been spending decades, essentially, as I said, trying to outsource this problem to vertically integrated entities. Instead, we need to build the public capacity to competently do price administration and to manage technology diffusion as the way to manage healthcare costs and equitably allocate resources across our healthcare system. This basically, the easiest way, the most succinct way to put this is to actually upgrade our Medicare system. Our traditional Medicare program needs a significant facelift from its passage in 1965. And then I would offer that to all Americans once it's upgraded as kind of if we can get to a silver bullet in terms of wrapping together all these policy concepts, that's the direction that I would move.
Okay, great. Well, I'm sure we could go on and on about this topic, but unfortunately we're out of time. So I'd like to just thank you both again for sharing your expertise with us today.